Hello, and welcome to the health track of Austin Startup Week. Coming on the heels of some really great tracks and some great conversations yesterday and today, particularly the mental health track and talking about all of the different challenges that we've been having. It is so good to keep those ideas flowing and share with you 3 super exciting sessions, as well as networking opportunities that are woven in so that you can meet lots and lots of the startup participants that are here as part of Austin Startup Week. I hopped into a few of those conversations yesterday, and I had some great conversations. I discovered some new leads, and I made some new friends that I cannot wait to meet in person. But before we get started, I should introduce myself as your health track lead and advisor, and why I am so eager for you to meet and learn from some truly remarkable guests today that are helping us to reshape healthcare. So I am Shawna Butler. I'm a nurse economist. I'm the managing director for the Exponential Medicine Conference, and I am the host of the See You Now podcast, which is focused on how nurses and health innovators are solving our most challenging healthcare problems. It's produced in partnership with Johnson & Johnson and the American Nurses Association, and it's a storytelling format where we take a look at it from the human-centered design approach, where we identify the problem, make friends with it just a little bit, but then what we focus on is figuring out how those solutions, remarkable solutions, how they're being designed and how they are solving these really wicked problems that we're seeing in healthcare. And in these roles, I get to have a front row seat to the science, to the practice, to the innovation and the technology that is fundamentally reshaping how we address our health and illness. And not only those technologies, but also these remarkable innovators who are, let's just say, seeing and wrestling with challenges that are almost unimaginable, but on a daily basis, the things that walk through their doors. And the solutions are remarkable, but not nearly as remarkable as these innovators. And their conviction, their imagination, their curiosity, their bias towards action and experimentation, and their sense of wondery and discovery, and I have to say, just a remarkable sense of humor. And also, before we get started on the track today, I want to send a huge shout out and thanks to our track sponsor. It's Texas Children's Hospital, and annually they see over 4 million kids. They have 36,000 admissions to their very large campus. They're one of the largest, most respected children's healthcare facilities across our country. They're made up of a team of over 15,000 nurses, physicians, staff members, and along with their executives and their community members, they're really continuing to invest every single day along with the community and focus on the mission of how do we have a healthier and happier future for children and families, and for the families who love and care for them. So before we get started, I want to ask our team if they will roll a quick video so we can get a better sense of Texas Children's.
Hello, everyone, and thank you for joining us at the virtual groundbreaking ceremony for Texas Children's Hospital in Austin. I am beyond thrilled that we've reached this milestone and extremely proud to expand our footprint in the state capital.
For the past few years, I've had the privilege and honor of working alongside a remarkable and dedicated team of individuals who spent tireless days, month after month, ensuring that Texas Children's could seamlessly expand our care to Austin, Texas. In 2024, we will open our 365,000 square foot, 52-bed hospital campus in North Austin. The same high-quality inpatient and outpatient health care that we have provided to our patients since 1954 will now be a part of the Austin community.
We already have primary care, subspecialty care, and an urgent care center in place. And now we are bringing exemplary inpatient care, pediatrics, and OB-GYN to Austin and Central Texas.
Our promise from the very beginning of this journey into Austin has been to deliver the highest quality care closer to our patients through our multiple locations across the city so that children and women can access the right care in the right place at the right time.
There's going to be a seamless continuum of care throughout our facilities here at Texas Children's for primary care, outpatient specialty care, and for North Austin Hospital location as well.
With each new location, and now with the Texas Children's Hospital campus in Austin, we have the ability to expand to more and more women and children who need our world-class, one-of-a-kind care.
When Texas Children's opened its doors in 1954, our founders envisioned a hospital that would serve all children in our community and give them the hope of a healthy future. Today, we treat children from all over the country and, well, from all over the world. And we want the children and women and families of Austin and Central Texas to have access immediately to the best pediatric and OB-GYN care in the United States and in our great state. And that is exactly what we are bringing to Austin and to the families who need us.
And every step we've taken to bring this care to Austin is helping us serve the state of Texas even more successfully and allowing us to truly be Texas Children's Hospital.
We're excited and honored to serve you and your family at our future hospital campus in North Austin, and we can't wait for 2024.
And we can't wait either. As somebody who's taken care of children and been in hospitals, what I love about how those pictures and those images they capture, oftentimes we think of pediatric hospitals as being sad, places where you think, oh my gosh, that's really heavy. But when you're there, it is just such a lift. And the specialties that they bring, kids are not just small adults. They really have their own unique needs. And the care that is given to them, the professionals around it, they're just remarkable. So anyway, let's get on with this track and think about why are we here today? Why is this track so incredibly important? I think what's important to acknowledge is we're at a critical moment in healthcare, and particularly in digital technology and how it's aimed at delivery, monitoring, discovery. And I'm so proud that Capital Factory is really determined and set themselves as the epicenter of health innovation and tech and biotech for the state of Texas. Capital Factory recognizes that health technology and policy are converging in game-changing ways. And with that expansion of health tech innovation, it requires a wide-ranging approach and one that has intentional engagement across all of our sectors. It's going to include the biomedical folks who are serving in government, industry, education, research, public and population health, as well as personal health. So in this track, we're really upholding the Austin Startup Week's legendary approach to serendipitous networking to identify not only who's in your sector, but also how we move upstream so we can think about prevention, cross sector, so we can think about all the different ways that we need to address health and human services, and how we're going to find those solutions through conversations with nurses, physicians, school officials, insurance leaders, all manner of folks who are touching the lives and the health of our populations and our cities and our communities. And we're going to dive into three very wide-ranging perspectives that approach the existing, the new, and the future health technologies, and the various partnerships that are going to be necessary to advance progress and change at a system-wide level. So the upcoming sessions that we have for you today, the first, we're going to have a fireside. Well, we've got this little fireside thing going on. It's a beautiful day here in Austin, but we're going to have a fireside chat with Vonda Wright, Dr. Vonda Wright. She's an orthopedic surgeon and has been working with sports and esports and technology and research and women's health and so many different things that touch our lives and improve our health, and particularly how we think about a digital-first approach to care, what that looks like in the range of technology that's available to us to keep us moving and happy and healthy and safe for everybody, especially our kids and increasingly our healthcare teams. The second panel that we're going to have is focused on the future of Femtech and discussing not only telehealth's role in improving women's health and their outcomes, but increasingly the allyship and the activism in a political and economic climate that has particularly and disproportionately been tough on women. And our last panel today is going to be focused on children, mental health for our pediatric patients, and the community interventions. It's a panel that includes school nurse, psychologist, physicians, and we're going to take a deep dive into how we absolutely must address adolescent mental health, the crisis that we're seeing right now that's expanded during this global pandemic. So we are really missing being able to have this event in person. But at the same time, we're really grateful for the technology that allows us to come together. So as part of Austin Startup Week, we're going to invite you to jump into a couple of networking opportunities. And the Hop On platform has made this super easy. So if you take a look on your screen, you should see a button. Oh, I have such a hard time with right and left. But anyway, it's on the side of your screen. If you'll click on that and go take a few minutes to jump into that networking session, and then join us in about 15 minutes where we start our conversation with Dr. Vonda Wright. And as you go into this networking session, I want you to be thinking of 2 questions to network with folks. And the first one is, what's your connection to health tech? And what are the problems that you're looking to address? All right, guys, see you in a few minutes. Thanks, and have a great time while you're networking. Vonda Wright has a distinguished background. Not only, I think my favorite part about Vonda's background is that she started out as an oncology nurse, and as if that wasn't hard enough, she decided she needed to add several more skills in her toolkit. And so added that grueling approach, or the grueling training to become an orthopedic surgeon, and specifically focused on sports. And throughout that career, she has started headed up some remarkable sports medicine programs, been the lead physician for many professional sports, as well as dance and marathon, and not just for this country's athletes, but for some athletes around the world. And she's also been taking a really important look at the role that women have in the health of their families, their communities, and generations. So without, I'm not going to give too much more away. I want you to get to know Vonda Wright, Dr. Vonda Wright. So if I can get our tech team to bring her up, let's go ahead and get started. So Vonda, hey.
How are you?
Oh, I'm so glad to see you. I think the bigger question is, like I said, you are a surgeon on the move. Where are we finding you today? Because I know that you are literally getting ready to move on many fronts.
It's a little bit of an odd setup we have here today, but you know, you are so right. I'm totally on the move. Thankfully, like you, I've got this capacity to keep all these plates in the air. So I have just finished a big build in orthopedics in Atlanta, where a big hospital system decided to build their very first orthopedic surgery department and brought me from the University of Pittsburgh to do that. And then now I'm moving to Orlando in the amazing medical city called Lake Nona to do it again. We're building a Privedemic group, which will be on the hot edge of innovation. How could I be in an innovation city like Lake Nona and not be trying out everything that's new from the brilliant minds, some of whom, you know, I met for the first time via some of your projects.
Yeah, I was going to say, it's fun to see how these things are overlapping. And one of the things that I wanted you to address, we're really at a critical moment in healthcare. Our systems have been stressed to the breaking point, some of them. Yeah. Some of them are about to break. And throughout the last 18 months, I think you and I have been early adopters of digital health, digital first, and thinking about all the different ways that we can identify an illness, we can intervene in an illness, we can treat, we can monitor all the surveillance. But during these last 18 months, while it was nice to think about it, and we were spending a lot of time encouraging administrations to adopt this, the pandemic forced us to go digital first. And I would love for you to share the situation that you experienced where we asked surgeons around the world actually to delay elective surgery and to be very mindful about which surgeries could be done. And this was at a moment in time, just, you know, I think so much has happened that sometimes we have to remind ourselves. It was a function of capacity, flattening the curve, and a shortage of PPE, personal protective equipment. So it's a crisis that forced us to do things that we would have never thought we were able to do or willing to do. So why don't you walk us through the experience that you had in taking a large health system into predominantly a digital first approach to orthopedic surgery?
Well, thank you so much. It seems like so long ago, it really wasn't. And we've adapted so much, and so much of now literally was not then, in the ease that we're doing it now, like this kind of thing, right? We could all just barely Zoom or whatever, before this all happened. And now every platform, including the ones we're using today, are second nature to us. So even what seems normal now was not normal then. So on March 13th, 2 years ago, I guess it will be, our hospital, for all the reasons that you have just cited, the ICUs were filling up. I was in the hospital that day when our ICU went from normal to completely full of COVID people. And it was literally like that. Our ERs were full. Thankfully, my hospital was very careful not to go on bypass, but they were prudent in trying to figure out who must go to surgery now, or who is truly elective. And as an orthopedic surgeon, most of us are elective surgeons, nothing, except for the trauma surgeons or the cancer surgeons, right? And so we had the hard decision of what is elective and what is not. We also had the hard decision of how do we actually continue to take care of the people who depend on us? Because one of the truths about most physicians and orthopedics in specific is that people come to us in the most vulnerable time, in pain. And so it's not an okay answer just to say, we don't know what COVID's going to do. See you in a couple years, right? So my group and the administrators that worked with us had been very painfully, arduously working at a pace that reflected that we were not sure that this was the way to deliver care on standing up telemedicine for orthopedics. At the time, there were not that many clinical applications for orthopedics, because they're like, don't you have to lay hands on? Don't you? Now, PCPs had done it, but the surgeons had not. Well, March 13th, by 3 days later, we made the decision to pivot, literally to pivot from peacetime to wartime. And in war, we have some of the most amazing medical discoveries and progressions ever. It happened after the First World War, the Second World War, after this long war we just got over. And that's how we treated COVID. And in 3 days, we stood up 25 surgeons on telemedicine on a platform that we had slowly been working through, committee after committee. IT wasn't sure that it was the way. Listen, COVID hit. We couldn't see our patients, and we pivoted. And I've seen example after example of how things that were, a slow boil, suddenly it was time to deliver. And you know what? We continued to care for patients, and we discovered that even in something as hands-on in orthopedics, we could provide a lot of care remotely.
Yeah, I want you to say more about that, because I think as we think about any surgical specialty, we don't think about necessarily how is this going to be a digital approach. And while there are certain clearly parts of the surgery that are not being done digitally, there's so much in the care stream that actually can be done remotely, can be done digitally, can be done through remote monitoring. So so that people can kind of get that picture in their head, and they're thinking, okay, so I might be an orthopedic patient soon. How do I embrace this digital approach to getting my orthopedic surgical care?
Much of great doctoring, great doctor-patient relationship is simply communication. Now, I have to lay hands on people to examine their body parts, but that's not always something that I have to do to progress someone's care, right? So I can have digital first communications and decide that you need x-rays, or you can show me. I've had lots of conversations with people when they're laying in bed. I know people just choose to talk to the doctors on telehealth in bed or on their couches, surrounded with their dogs, and at 9 o'clock at night. I mean, it gives access where access never was, right? So we can have preliminary conversations, after which I can order x-rays, or I can say, you know what? It sounds like you need to be in here. I mean, even now, this is the things we do. There are points in time in the follow-up progression where it really is a conversation. It's not necessarily a ton of hand holding or hand laying on of hands. All those visits can be done remotely. In fact, we extended our care from simply telehealth visits to remote patient monitoring.
Yeah.
We enrolled people, and you wouldn't think, how could orthopedics do remote patient monitoring? Now, there are some sticky rules, and we did a pilot to try to figure out how to be compliant while providing remote patient monitoring.
And let's name, I'm just gonna say, for folks who are listening that are not really steeped into remote patient monitoring, we're talking about blood pressure. Yeah.
So you can do, medical doctors tend to do a lot of symptom checking, of vital taking. In orthopedics, I had a device, and I still use it. It's called Fusionetics, where we can look at your motion on an app on your own phone. We download it onto your phone. Your friend holds it up. It sees you. It sees how you're moving. And I like to onload people live, but I can then follow them multiple times, because once you go on, you're giving me your data about how compliant you are, how much motion you had, and I can see that with or without you, right? So I have the ability to constantly monitor you in a way that before that, I would have to wait certain time periods.
Right.
And sometimes, if we wait 6 weeks to see you, I probably should have intervened in 3 weeks, right? So that's how we're now using technology of seeing cameras that are able to relay information besides simple blood pressure. Although, Shawna, you were involved in a project where there is a real there's an actual tricorder now. It just scans you, all that data comes in. Well,
it's very Star Trek. It totally is Star Trek. Yeah.
This is the orthopedic equivalent. And from that, in our pilot, we were able to monitor patients' compliance, call them once a week, offer tips, see, are you doing okay? Notice we haven't seen you in about 10 days. Don't forget you're important in this process, and that kind of coaching.
Mm-hmm.
So actually what it does is it increases the touch of care from a typical orthopedic experience. So we did telemedicine, we did remote patient monitoring, and one more thing we did, which we tend not to do in orthopedics, but during COVID, when people had to choose whether they came in or not, or how many we allowed in, I had some of my staff, we devoted a specific team, call each and every one of our patients in our database to say, how are you? Are you getting your follow-up? If you're having chest pain, you still go to the ER, because people thought they couldn't come.
Yes. I can say, right? we did. We let people know, please don't come, and that wasn't just ERs. That was our primary care providers. That was folks who were child visits.
Yes.
And, actually, while you speak to that, I do want to ask you this question to see what your add to this is. So in different verticals in health, and I'll use the maternal child specifically. So delivering a baby during the pandemic, that got hit really hard. So how we had to reconfigure our neonatal intensive care units, our maternity care and delivery, dramatically changed, and particularly when it comes to support. And what many of the maternal child care providers have found is that by using telehealth, what we had is this sequence, a cadence of visits. And it was saying you needed to come in like once every month. Mm-hmm. And then as you got closer, once every week. What they found by doing the telehealth visits is that actually those were kind of arbitrary. I mean, they were good guesses, but exactly. So what they found is that it actually allowed them to personalize and to get more specific with the care. And it dramatically changed the sequence of all of that, but also it gave them an opportunity to address the mental health and wellness, and also the situations, because when we would have everybody come into the offices or to the practices, we weren't getting to see what people's lived experiences were. And there were just so many things that they picked up on to say, here's some things that I think can improve your care. So I'm curious, with your experience, what things did you guys learn doing this digital first approach, remote, virtual, that you probably would have never uncovered or unsurfaced if you just kept delivering care the way you had been?
I love that you cited the arbitrariness of follow-up care. Like, I don't know where it came from, but I do what my mentors did. And some of it is dependent on, for surgeons, the first 30 days after, or the first 3 months after a surgery actually are included in the surgical cost. And so some people make their decisions based on the economics, which may or may not be what your patient needs. But what I have found is that I did have a set schedule, but like I said to you, sometimes my patients needed to come in earlier. Now, it is my practice to be digitally connected to my patients at all times, and I want to talk to you about that a little bit.
Yeah.
But it is not all doctors. Some people have better boundaries than me. So I don't want someone swimming around in the community getting a stiff joint without me knowing it, right? So this digital connectivity where people don't feel like they're bothering the doctor when they can just report on their digitalness and we'll see it. So it enlightened our view of what our patients actually live through. Something else that happened during the last 2 years is there were a lot of companies dabbling in secure texting, and most of us didn't use it, frankly. We just used regular texting, if anything, with our patients, right? Now, less than 2 years later, not only there are a lot of companies doing it, but it's the norm. Patients want, in fact, this new company I'm joining, that was one of the first thing I asked them, do you have a platform where when my patients leave my office, I can thank them for the visit? I can tell them what they need to follow up. When they're coming in, I can remind them, keep in touch with them. They can text me back and forth. It connects to my medical record. Thankfully, the answer was yes. But that kind of constant play back and forth that prevents complications, frankly,
Right.
and increases the sense that, oh my gosh, we're being taken care of, is really in the forefront because of what we experienced with COVID. It is the norm now. It was the exception before. It was like, Shawna, at your conference at Exponential Medicine, it's like, oh my God, what a cool thing. You can talk to your patients all the time. Wow, they're innovative. Now, those companies have been pushed to the forefront, and we're wondering what's next. You know, like somebody's going to live in my house, or I'm in Lake County. The houses are smart here.
Yeah.
They know how I feel by the sound of my voice.
Yeah.
It's a little frightening, right?
Well, when you bring up, the smart and the staying in communication, what we're finding, so now we've gotten comfortable with having the text, which is live, dynamic, and what we're seeing, like across the federally qualified health centers, some of the things that they're doing. Okay, so you came in to see me for a respiratory issue. But when they start taking a look at all their prevention and upstream type of things, because I've established a trust relationship with you, I can mention, hey, we've got a really fabulous screening going on for the following types of cancers. And you know what? As a patient that you fall into these categories, here's something that I can recommend to you. Or as they start taking a look at community and population health, there's a new walking trail that just got opened up. So we're finding that the technology allows us to actually have a relationship around health, not just the illness and not just that intervention, but it is really interesting to see all of those different health campaigns. And when you've got somebody that falls into a specific demographic, and particularly those where they've been marginalized, it gives us a trust-based relationship to reach out to them. And this technology and our comfort with it and coming digital first, I think is really pushing that forward. I know we don't have a whole lot of time here. We could talk for forever, but there's something that I wanted you to share that you enlightened me to, that very first time I had ever heard of it. We've been talking a little bit about mental health and how in this moment, you've actually been able to check in with people. How are you today? Are people checking in with you? Oh, actually, before I forget, has these technologies helped you work better as a team? I want to make sure I ask you that one.
Well, it's helped us work better as a team in a compliant way.
Okay. If there's more to that, we'll get to it. But I didn't want to forget to ask you and like be completely off on another tangent. Because I think we do need to find tools that help us work together collaboratively across disciplines, specialties, inpatient, outpatient, home, all of those other things. But anyway, on the social and emotional well-being of all of us, kids have been hit particularly hard. And your practice, you see a lot of kids. You were the very first person to identify to me that there is an epidemic of youth sports injuries that have a long-term lifetime impact. And so when you're thinking about, I mean, with kids having to do hybrid schools right now, being in quarantine, not getting into their sports. I think as a parent, as a nurse, I'm wondering, are they at greater risk because they're not as conditioned? What do we need to do to keep kids safe, active, connected, building healthy identities, healthy patterns, lifestyle patterns of being active, just moving around, whatever sport or discipline that they want to identify with?
Oh my gosh, you realize this is an entire
I know. It's a lot.
So let's set it up, right? On one hand, you've got kids in our country sitting on their rear ends, not getting out and moving around. We've got, I don't know what the statistic is, maybe 30% of our kids are classified as a BMI that's dangerous or obese. We've got 17% diabetes. So we've got a problem with sedentary people. We are designed to move. Our strongest muscles are below our belly button, right? So we are not designed to sit around. So we've got some kids that do that. On the other side, we've got kids really pushed by not only their initiative, I will accept that, but by the industry of youth sports, which is a financially driven industry because less than 2% of all children become pro athletes. So don't tell me that we're thinking about their futures, and driven by parents who want the best for their children, not only because they want the best for their children. And listen, I've been involved in the raising of 6 athletes through my marriage and through my own children. And so I'm speaking to you as a mother and a surgeon. I get it. We want our kids to have athletic success, but sometimes, let's be honest, we're living vicariously through the success of our children. So we've got the sedentary, we've got the kids pushed into sports, and these kids who are pushed into sports with early specialization, meaning choose your sport at age 7. You can only be a soccer player. You can only be a swimmer, right? The best athletes historically were always multiple sport athletes. We're just developing their athleticism, not their skills, right? So here,
or their position,
their position sense,
Yeah.
right?
Mm-hmm.
So they're starting really young. They're specializing early. They're playing year round without rest periods. And what's happening to our children? Many of them quit organized sports by the age of 13 because they're burnt out and it's not fun anymore. So then all those are dumped into the sedentary pile, right? They're getting injuries that can be life-changing. People, you can change the shape of the bones by the pressure you put on your children's bones. You can damage growth plates. And you can lose cartilage that never grows back. So I want us to take a very steady and thoughtful approach to getting our kids more active, allowing them to learn the amazing things that they learn within group and competitive sports without skilling them to death, right? Using their skill to damage them. And I wish I had coined that word, but I didn't. Gary Gray did. He's a great therapist out of Michigan. But we're literally skilling our kids. And it becomes even more complicated, honestly, Shawna, now that we are going to pay college athletes for their life.
There's compensation for their use of their likeness. Yeah.
Now, I want people listening to me to understand where I'm coming from as a sports doctor. I love sports. It's my livelihood. I've been on a field since I was 18 taking care of people. And there's nothing like it to teach life skills. Great executives come from historic athletes, but we can do better, right?
And I want you to speak to that better because this year, Naomi Osaka, Simone Biles, it has been forefront. We just talked about the stress on the body, the physical part, but we've heard it from athletes like Michael Phelps. So many different athletes have shared the stress, the mental health issues. And so we want to keep their bodies safe, their physical body safe. The pressure, there's the mental safety. I mean, when I talk about keeping kids safe, there's many dimensions that we need to talk about. And, these are elite athletes. Again, the vast majority of children will never be in that. But that doesn't mean that they don't have the same issues and mental health stresses and safety issues. And, as an orthopedic surgeon, I think you are very well positioned to speak to what we need to do to keep kids safe on all dimensions.
Yeah, I want to talk about two specific things surrounding that idea. Number one, when I first started taking care of athletes, I was a athletic trainer in college, so when I was 18, so it's almost, I don't want to tell you how old I am, but a lot of years.
Wise, you're wise, you're ageless.
It was only physical. About 10 years ago, we started to see a change in our college locker rooms where we were having a lot more kids coming in with, well, maybe athletes have always had anxiety, depression, mental health needs, and we maybe ignored it. I mean, I'm willing to accept that maybe we didn't know enough, but about 10 years ago, we started implementing mental health programs, hiring social workers to be in our locker rooms, because kids, even though high functioning on the field, had tons of anxiety. We would have kids cutting themselves, trying to express their hurt in damaging ways. So the sports community is now doing research, is publishing on it, is recognizing that we have to take care of the whole person. But I want to also be the one that opens up a conversation about the role of physicians and parents and children educating kids on what it means to be safe in their environments. I have taught my children, my 14-year-old daughter, from the minute she was born, that it's her body and she decides how it's touched. She doesn't even let me slap her on the leg because she'll say, "Mom, you said it was my body, and I said that was not okay." Kids don't know that when they're brought into a place where someone's an authority over you and they think it's okay that maybe they're being touched in an inappropriate way, or maybe they don't know whether it's appropriate or not, but they're like, well, I'm in this place that's supposed to be safe for me.
And all the adults around me
say, okay, well, so we've had multiple sports now where women in particular and some men have been in damaging situations. I mean, the gymnast just went before Congress, right? So I think as a community, the medicine doctors, the surgeons, the parents, the kids themselves need to understand that safety comes on all fronts, that it's your body. You get to decide how someone touches you. And if it seems weird to you, ask a question. And it may be just how I have to examine you. I'm a hip doctor. I got to put your leg in all kinds of weird positions, but I usually explain to you what I'm doing and why. And if somebody doesn't feel comfortable, I stop and I say, okay, well, that's fine. I'm not going to be able to get that piece of information. But I think giving people permission, young kids especially, to say, hey, what are you doing and why, will be the beginning to preventing the terrible badness that we've seen going on in sport.
And, I thank you for bringing that up, because keeping our kids safe on all dimensions is a collective responsibility. Mm-hmm. And I feel very committed as a healthcare professional we have a license to touch. Yeah. And with that license to touch comes a sacred responsibility to keep people safe. And they trust us. Yeah. And we need to be the first ones to be their advocates and to keep them safe. Yeah. And when I think about all of the different things that we have ahead of us, I'm really grateful that there are courageous and bold leaders like you to help bring these topics to light, to give us solutions and approaches, and point us to the research and the evidence, and to make sure that we are paying attention to this. And, yes, to the problems, to the challenges, kids are being sedentary, not having great, healthy weight, their BMI, higher rates of diabetes, there's so much going on there. But what I've always heard you say is, while you identify the problem, you are the first champion of all of the solutions that are out there. And I'm really excited that kids are coming back into community, that they are getting back with their teams and their sports, their dance troupes, their orchestras, their robotics teams. There's a lot of way to be moving. There's a lot of different way to bring sport into Latin, reading, things that we don't necessarily think of as sports and competition. So Do you have any, I mean, I know that you need to run. Literally, you got to fly.
But I don't want to end on a negative note.
No.
Speaking passionately, but here's what I want your audience to understand. There are ways that we have opportunities to do better for all populations, but sport, getting to be a sports doctor, it is a privilege, Shawna. I think I've always said this to you. What a privilege that the very first time somebody meets me in my office or other physicians or other nurses, they decide to trust us. And with that profound privilege comes responsibility. And what we want to do is just make sure that we're delivering the best care all the time in the most technologically advanced way, because that's where we are now. And so, I mean, I it's a true joy and bliss to be a surgeon. It is. And so, and to get the platform with you today, I'm very thankful. So thanks for inviting me.
And before you leave, where can people find you? You've got great content, books, audio.
So I'm all over social media at Dr. Vonda Wright, Dr. Vonda Wright. I have a website by the same name, and I have this fascinating, I think it's fascinating podcast, which you've been on, called Hot for Your Health, where we have a variety of great personalities and clinicians talking about what's hot for your health.
So let's get into this next conversation. Crunchbase and lots of other industry observers have been paying attention to the Femtech space. And they report that the Femtech industry is growing and it's an appealing market. A segment of this growing market actually is dominated by women's telehealth services. And these telehealth services are super important in bridging the gaps of access. We often talk about the last mile. And within the last mile, it's made up of a lot of different inches. And in figuring out how we take care of women and children and families, we need to really take a holistic approach within healthcare, one that recognizes the intersection of social circumstances and the health realities. There's a growing awareness of health disparities and health inequities across all our health indicators, but especially when we start taking a look at women's health and women's health care. This really requires a multifaceted approach that can potentially improve every aspect of a woman's health, particularly reproductive health, maternal and newborn care, and the outcomes, and the experience that not only as healthcare professionals we're delivering, but also as people, what is the care that they're receiving? What is that like? And also, we get to talk about closing the pleasure gap. So let's get this party started. And I'd like to invite our guests, Brittany Barretto, who will be moderating the session. Let's go ahead and bring them up on stage. Siggy Marmestein, Kiki Friedman, and Fahima Sasson. I probably just butchered that, but you guys get to introduce yourself. And I am so glad you're here. Brittany, go ahead, take it away. And I love the fact that you wore the power pink.
Yeah.
I totally missed the vote on that one.
All day.
Good on you.
Hair, blazer, all of it. You know how we do. So thanks, Shawna. Hi, everybody. I'm so excited to be leading this Femtech panel. So excited. I am Dr. Brittany Barretto. I am the host of the Femtech Focus podcast, the #1 Femtech podcast worldwide. We also are the leaders in market research, partnering with PitchBook and Crunchbase on the Femtech industry. So I'm really excited to introduce you to 3 rock stars in the space. I always think people do themselves more justice than a host can, though. So I'm going to let them all introduce themselves, tell you about their company a little bit, and how far along in the process they are. Siggy, would you like to go first?
Sure. Thank you so much, Brittany. So awesome to be here. I'm so excited. Siggy Marmestein, the CEO and founder of Baby Life Advice. It is a company I founded in 2019 to support maternal and infant care from preconception to early childhood using telehealth. I'm also a nurse practitioner in my profession and a telehealth consultant. I have about 65 telehealth implementation under my belt, so this is just one of them. And I'm very excited to be here today. Thank you, guys.
Excellent. Kiki.
Hey, everyone. I'm Kiki Friedman, CEO and one of the co-founders of Hey Jane. We're a digital clinic offering complete care for women and other people with uterus's most underserved health needs, starting with medication abortion care through telemedicine. We launched earlier this year. We're live in 3 states and have a growing team.
Very important. And which 3 states, if you don't mind just telling us real quick?
We are in New York, Washington State, and California.
Excellent. Awesome. Fahima.
Hi, I'm Dr. Fahima Sassan. I'm Kindbody's founding physician. I'm a board certified OBGYN and also our chief medical officer of obstetrics and gynecology. Kindbody, we actually have brick and mortar and virtual. So we are a national network of women's health and fertility practices with a true focus on reproductive health for all. So including a real huge emphasis on male fertility, female fertility, as well as the LGBTQ community. We have currently 12 locations across the country and about to open 12 more in 2022. We just did during COVID, which was a monumental feat, completed our Series C and raised $62 million, which is the most money raised by a fertility company in history. So that was something we're really proud of and very excited to be here with you guys today.
Excellent. I hope, listeners, that you can see that we have a really unique tangential telehealth group here where we have, abortion care, fertility care, and maternal health and postpartum care. So it's really exciting. I do really quickly want to say that women are more than just wombs, and Femtech actually also includes things that solely, disproportionately, or differently affect women, such as heart health, brain health, bone health. If you want to learn more about that, again, check out Femtech Focus. But today, let's talk about how telehealth is integrated into maternal health and abortion and postpartum care. Let's start off with Dr. Fahima. Can you even do obstetrics and gynecology via telehealth? Because my experience has been my heels have to go in stirrups. So how does that work with telehealth?
Absolutely. That's a wonderful question. And absolutely, telehealth plays a huge role and needs to continue to play a huge role in the delivery of obstetrics and gynecologic care. And regardless of where you are, from menarche to menopause and beyond and everywhere in between. Hopefully, COVID is showing us that we can do so much more than we ever imagined through virtual spaces. And I think healthcare tends to be slow in the uptake of technology sometimes. So I'm happy to see that my colleagues here are huge proponents of using this platform. But absolutely it can be, because if you think about it, a great deal of gynecologic care and obstetrics care is consultation. And we all know you don't need to be sitting in the same room to counsel and to go over options and to review symptoms and medical history and all these, and actually even completely review with someone all of their treatment options and choices and management techniques that are available. And so what I think that becomes a really nice thing that we do at Kindbody is we really marry virtual and in-person treatments, so that there's a lot of aspects of a person's care, whether it's a follow-up visit or even that initial visit, that can occur virtually. And then when needed, and I stress when needed, we can do an in-person follow-up. So maybe a person does need an ultrasound, or they need blood work, or they do need an examination or a procedure based on the discretion of their provider, then that can be scheduled at a convenient manner. And that allows us to reach rural communities. It allows us to improve access, because listen, not everybody works or is available to go to a doctor's office 9 to 5, but also allows us to improve the provision of care we provide for men and women who maybe just don't have the ability to physically go to an office, either because of a child they're caring for or just access to transportation or whatever the case may be.
Absolutely. I just heard you say, like, over the last year and a half through the pandemic, we've realized, oops, you don't always have to come in. We can do it through telehealth. Well, Siggy, you have been an OG in the telehealth space for decades, well before the pandemic. You're like, yeah, about time, everybody. How have you seen telehealth specifically for women's health change from when you first started working in there to when now?
Well, definitely telehealth is where it's at right now, right? Telehealth, telemonitoring, capacity building, internet utilization, internet networks, right? Things that were not there in 2009. The cell phone, everybody has a cell phone. I mean, 87% of the world has cell phones at this point, not necessarily all smartphone, but definitely all cell phones. These are big development that we are seeing, the cost for data. has gone down. In 2009, when we asked the patient to do a telehealth visit, it would have cost us and them about $15 to $16. Now it's more like in the cents. So this allows us to do more for less money, right? But in women's health, what I'm seeing is finally that catch up happening, that women are willing to finally utilize these modalities for their care, understanding how busy they are and how overwhelmed they are with life, especially in the last 2 years with having to have homeschooled kids and having to leave their jobs in order to just deal with the pandemic. Obviously, telehealth became very valuable to them, extremely forefront and center of their day-to-day interaction with their physicians, psychiatrists, psychologists, nutritionists, and other. In the healthcare, in maternal specifically, I would say that in maternal care, we have seen a lot of physicians reducing the amount of appointments that they were available for those women, but you are still pregnant. Pregnancy doesn't go away just because your doctor's office is closed. You still are pregnant. You still need your care. So moving virtually into that care was something that almost had no other way of doing it. We did not want to expose moms to the COVID. We did not want to expose babies or new infant born to COVID. So the only way to have provided them with some care, not putting them in the stirrups or doing this ultrasound, was at least to do the virtual care. Baby Life Advice is actually an extension of the services of providers. What we are allowing providers to do is get a break of that life and not keep them on the hamster wheel. So they are not burning off and eventually leaving their practices, leaving right now 10 million women in maternity deserts. So what we do we are physician extenders. We provide them the care that in between physician appointments, if you may. And we've seen that something that is very needed is, unfortunately, women right now are getting most of their information from Dr. Google, Facebook, Instagram, or the chat group of, other women who don't know anything like they do. So I see a lot of changes in telehealth, and I'm very excited about what's coming for telehealth. I do want one thing to say really quickly. Telehealth is not video conferencing. And a lot of people are talking about it. Well, we're doing a lot of video conferencing. We're doing telehealth. That is not what telehealth is. Interoperability, ability to bill for our services, the capacity to integrate different systems into a video conferencing. That is telehealth. We are not quite there yet.
Interesting. Oh, I love that little hey, by the way, yes. Kiki, was telehealth based abortion or access to, terminating a pregnancy even a thing that anyone thought of pre-pandemic, or is it like a pandemic derived idea?
Yeah, I would say certainly people were thinking about it before we started Hey Jane prior to the pandemic. But there were a few really critical changes that needed to make place for it to become a mainstream option. And just to give some context on the model for folks who may not be familiar, we provide access to the abortion pill. So 98% effective at ending unintended pregnancies up to 11 weeks, incredibly safe, lower adverse reaction rate than Tylenol, actually. But prior to the pandemic, there had been, sort of referencing some of the other panelists, a lot of unnecessary testing around the treatment, requiring in-person ultrasounds that were not really necessary or effective in achieving the goals that they were set out to do. And there had been guidance actually for years from some of the leading organizations to start ramping those down, but folks were slow to do so. So I think the pressure of the pandemic forced that forward, as well as unlocking a really critical opportunity to collect more data, driving the safety and effectiveness of this particular modality of treatment via telemedicine. So at the beginning of the pandemic, folks may have seen in the news, but many patients were traveling across state lines, hundreds of miles to reach an abortion clinic, and in doing so, exposing them significantly to pandemic risk. And so due to various court cases and other regulatory shifts, there was a window of opportunity to test this model. Many folks did so, and it did just add to this growing pile of evidence showing that telemedicine abortion is safe and effective. And fortunately, that evidence has now been heard by regulators to drive forward some policy changes that we think will make telemedicine abortion here to stay. So,
and we will definitely talk about that, especially as we are in Startup Week in Austin, Texas. So we are definitely going to have a few questions about that for sure. Dr. Faima, how has telehealth changed postpartum care, and why is that even important? I mean, I know everyone here knows postpartum care to be very important, but I think a lot of people focus on the pregnancy and then the baby happens and everyone's like, oh, she's on maternity leave, she's doing great. But actually she may not be. How is telehealth helping women postpartum?
Right. So one of the things that I'm really proud of for us at Kindbody is we really do provide the full continuum of care for women within our brick and mortar clinics. So we see patients as gynecologic preconception visits. We take care of their fertility issues. And then, and one of the biggest facets of some of our clinics is we also do the full suite of prenatal care and then the postpartum care. And anyone who has any familiarity with obstetrics, we call it the Forgotten Trimester, and that there's a lot of emphasis. I still think we can do better, but there's a lot of emphasis on a woman during her pregnancy. But once she delivers the baby, it transitions fully to pediatric care. And the standard in the United States is a woman who has a vaginal delivery has one postpartum visit. That happens at 6 weeks. And if you happen to have a C-section, you have 2 visits. And the one visit, I call it a mini visit because it's really meant to check your wound and isn't really time isn't spent on exploring all the other issues that you have. And so as a result, women experience really devastating crises, both emotionally and medically during this 6-week period, because there's so many transitions occurring hormonally, emotionally, and physically. So this is a period that unfortunately is riddled with a great deal of hospital readmissions, risks of seizures, even maternal death. There's huge risks of postpartum hemorrhage, bleeding, and then of course, postpartum depression and postpartum psychoses and psychological issues that can happen. And so virtual health and virtual visits and telehealth becomes this amazing opportunity for me as a physician to be at your home with you, not making you leave your house with a brand new baby, because we know both, from a convenience perspective, but also from a practical perspective is not wise. But I can empower you by giving you a blood pressure cuff that we give to all of our patients, which is easy. It's automated. You can utilize really nice surveys, postpartum depression screening tools, things like that. And then I can actually see you and speak to you. And that way I can see what you look like. Are you okay? Are you tearful? We can talk as long as we need to about issues that you may be having, down to lactation support or mental health, nutrition, watching your blood pressure. And then I can easily also connect you then to nutritionist or lactation consultant or mental health therapist, also virtually, to really be this beautiful continuum. And so what we've done now is change that standard 1 or 2 visits to now a standard of 6 to 8 visits, which is amazing.
Mm-hmm. Just to let you know, you're having a little bit of internet issues. So as we do questions for the other 2 ladies, I don't know if there's another Wi-Fi access point for you. Siggy, as she was talking about for mental wellness and the burden of, the postpartum depression and the hormones, is telehealth able to address mental health issues for women better?
Oh yeah, much better. Of course. I mean, so if you think about telehealth, and you were saying, that I've been doing this for so many years, in 2009 to 2013, most of telehealth was done in mental health. So mental health is probably the oldest of the telehealth modalities that we have been using in the United States, and not just in the United States and around the world, because truly it's much easier almost as we are conversating, right? You don't have to be laying on my couch. You can talk to me and we can talk on the phone, or we can have a chat. And we can also do a lot of work as we do in here right now. So mental health in telehealth has been actually the oldest modality, also have the most reimbursement, allowed to be around state lines. There is a lot of wonderful capacities in mental health. So postpartum depression is actually and should be probably handled mostly in a telehealth modalities and group setting. I have to always bring up PSI, which is the postpartum consortium, depression consortium, Moms 2020, who have done incredible work in training people to be support group leaders for moms in postpartum depression support groups. Those are just growing, unfortunately, by the pounds. We started off with about 40 of those, and are up to about 300 of those a month, and they're all full. The postpartum depression, by the way, is not just a woman issue. I want to mention that is a partner issue, and can be a male issue as well. And we've seen a lot of fathers with postpartum depression, especially and unfortunately if the wife have had a terrible outcomes or got really hurt in pregnancy. Those guys take it really hard. The partners take it very hard and made themselves, go into depression.
Yeah. And we are definitely pro men in Femtech. Women don't just birth other women. We don't just interact with other women. Women's health is everyone's health. Absolutely. Kiki, let's jump into some disparities in healthcare. I know that's a big thing right now. The pandemic has finally opened a lot of people's eyes to what some of us already knew, which is that not everyone gets the same healthcare based on your zip code, based on your gender, based on your race. And so can you actually tell us a little bit more about how telehealth helps even the playing field for women to get access to healthcare? Can you give us some examples of this?
Yeah, absolutely. I think there are, of course, some of the more obvious ones that are more commonly discussed, things like geographic access. I recently heard telemedicine abortion being described as geographic arbitrage because no longer are people needing to drive hundreds of miles to get to a clinic. Of course, because of the efficiencies that tech is able to drive in this model, we are able to offer care at much lower cost, and just generally much more convenient. That said, in doing this work, we've seen some other potentially more unexpected ways that telehealth can increase access. We've seen, for example, we offer, what's called an asynchronous model for consults, where folks can just chat with us rather than have a live conversation. We've seen that be really useful to people who may be in dangerous home situations, suffering from intimate partner violence, who cannot be overheard by other people within their household. Because of the technological component as well, we're able to offer full 24/7 support, which I think is very unique relative to an in-clinic model, where people who may be having difficulty either physically or emotionally with their treatment can reach out at any point for further contact. There was some interesting research published recently about how medication abortion drives less dysphoria among trans folks and other, members of the TGE community. And I think being able to facilitate that through this really supportive at-home environment with telemedicine is really huge as well.
Yeah, based on the gender you're presenting, it may not feel comfortable to go into specific offices, right? And so telehealth would be able to facilitate that. Siggy, you were telling us about this thing called maternity deserts. What's a maternity desert?
A maternity desert is actually a concept that was brought up by the March of Dimes when they were looking to see where our OB-GYNs are available in the country, and then also maternity ward. And they were able over the years to map out what does that look like. And if you look at the map, we have full-blown states with maybe one maternity ward, maybe 2 or 3 OBs, and that's about it. So serving millions of moms in an area where there is no access. So this is an access to care issue, health equity issue as well. By the way, it doesn't mean that in those states that the people who do serve those moms look like them or are like them, or that are even from the same, cultural or linguistic background as them. So that increases the maternity desert in respect of who is providing the care in those states and what are they predisposed to care for the mom like. Unfortunately, right now, and as of COVID, we have just lost another 43,000 OB-GYNs. So we are now at close to a total, by 2025, we'll have 96,000 less OB-GYNs than we need in this country to serve the amount of moms that are coming into age or the childbearing age.
Siggy, where did they go?
So 2 things are happening which are really interesting. Who is taking residency spot in GYN in the medical schools are actually women. More women are going into the GYN business, if you may, but they are not full-time employees. Many of them are actually will go in and work in part-time, reducing the amount of actual appointments that are available, if you may, for those mothers. The others we have a huge retirement and, from the profession. And with the payment models, the risk models that are in this profession, less and less people are likely to walk into that. people don't notice, but the OBGYN will pay more malpractice insurance than a brain surgeon. So obviously, with that kind of a risk, maybe not as appealing for people to go into the profession or stay in it.
Yeah. Well, this is actually quite serendipitous. My next question is about infrastructure for internet and access to broadband. So I think this is it's the universe just helping us out here on a great.
There you go.
Dr. Faima, how are we able to reach women that don't have great access to internet?
Yeah, no, I think one of the big things that Siggy mentioned was that everybody has a cell phone nowadays, and truly, and the majority of places where to understand that you really truly only need a cell phone in order to be able to do a lot of these visits with the appropriate. And I do want to highlight that Siggy mentioned the importance of having the proper infrastructure in place, obviously, as we do here at Kindbody for billing and coding and making sure state regulations are in place. It's not just a Zoom visit. But with that said, I think just the access that the general population has to cell phones really makes this impeccably easier. And also then recognizing that there are opportunities where we as Femtech leaders can help people who even maybe there are people out there who have really poor access and where the biggest disparities exist, where maybe even cell phone or Wi-Fi access is limited. And I think these are opportunities where we as women can help other women. But for the most part, I think just looking at even like Facebook yesterday that went down for a few hours and the whole world was in a frenzy, I think is a testament to the fact that Wi-Fi exists, access to Wi-Fi and computer access, whether it's your own private or you're using it through public outlets that allow people to use it. I think it's becoming less and less of a problem. Certainly, it's an opportunity for us as people in technology to continue to help those areas. But for the most part, I really think that it's now a very small issue.
Mm-hmm.
Can I say something to that, actually, just to let you know? I myself drove the other day, took a road trip, if you may, and went around from here to Oregon. And I had a good maybe 22 hours with no cell phone reception at all. Just to give you an example of when there is a reception, I went to Africa. I went to Chagoria, which is up in the mountains of Mount Kenya. And we had better reception there than we had here in Oregon.
Right.
So there are still huge issues of reception and internet in rural communities. South Dakota is the center of the United States. In fact, there are many, many places that you're not. We still do phone visits, you guys. The phone is still working every single time. Another thing that we use in a lot is what we call hubs. So local churches, local community places, the local markets. Walmart Health is something that, we have used to have people come to the store and take, a kiosk. So many other opportunities. We always have to think outside of the box. But, unfortunately, even with the cell phone, yes, people have the cell phone. Wi-Fi, not necessarily always there, but we still have to lay down those network and continue working really hard on that.
Absolutely. Wi-Fi is no longer a luxury. It's a requirement. Dr. Faima, I know you have to leave at the top of the hour, so I want to throw one more question your way. You've been so great to move rooms for us. There is an issue with racial discrimination in the healthcare system. Black women die 3 times more than white women from, childbirth. So do you think that telehealth could support decreasing these microaggressions or these larger discrimination issues for Black and brown women?
Absolutely. Well, I think first and foremost, this is an area that we at Kindbody feel really strongly about wanting to improve. We recognize, especially in the fertility space, that there's so many huge disparities when it comes to women of color and African-American women and their access to care. And so certainly telehealth can help improve that access by the virtue of companies like ours that go out and say, hey, every woman, every man, we're here to help you, that we're taking away some of the natural barriers of you must go see a doctor who must refer you to another doctor, and just being able to direct to consumer reach patients and people, I think allows us to take away some of those barriers. But also a huge part of these barriers is cost. And a lot of times these telehealth platforms, and companies like ours can help substantially reduce the cost, which can bridge that gap.
Yeah. Well, thank you so much for joining us today. I know you have to run. And I also see questions coming in. Please keep them coming. We will address them, definitely. My last question here is for Kiki. Elephant in the room, the Texas abortion ban, and you're doing telehealth abortion. I recently saw a quote that said, the Institute for Women's Policy says that the economic losses in Texas that will result from the abortion ban are at $14.5 billion per year, just based on the impact it'll have on the labor force and earnings of women. Can you provide us some more information about, is telehealth going to help Texas? Is it like, what do we need to do? What's going on?
Well, I hope so. As brief history there, even prior to SB 8, telemedicine abortion was not permitted in Texas. So there does need to be some substantial regulatory change to make it viable in sort of a mainstream sense. But I would add two ways we're thinking about telemedicine addressing the problem now. One is through facilitating easier cross-state care. In Texas, I think that that's become an urgent issue now. And as we look towards the unfortunate but real possibility of a post-Roe world, that may become a very critical component of access. And so telemedicine, by allowing people to get care at like the closest border point to their natural travel route, and being able to allow them to get access to treatment much more quickly than a clinic typically would, where you have about an 8-day wait on average, we do think that will be an additional supplement to ongoing in-person care to provide a further road towards access. The other is that we no longer are in the world where we need to go towards the, stereotypical back alley approach. There are great resources out there like Aid Access, like Plan C, that are providing ongoing care through telemedicine abortion in a somewhat extra legal sense, but when that it is still safe. There's been great research to show that the pills that they are sending are the same as the FDA-approved medications dispensed in the US. There are downsides to that approach, and it shouldn't be the case that folks are forced to go through an extra legal route, but it is an optimistic outcome that at least the extra legal routes are much safer than they were in the past because of telemedicine.
Yeah, I noticed that, and this is a question that I'd like to actually post to the group, but Kiki, maybe you can go first. This is a question from the audience. How do we get big companies to pay attention to women's health and their experience? The first version of the Apple Health app didn't include tracking your cycle. And it was like, well, there wasn't a lady on that team, there's still no pregnancy settings, right? So all of a sudden women are pregnant and the apps are saying, why are you so fat and lazy? You're eating too much and too sedentary. And it's like, I'm pregnant. And then also with this economic loss, right? How are the people like Tesla going to Austin going to be able to recruit the best women around the country who are going to want the right to do this, whether or not they personally will, right? Kiki, how are we going to get big companies to pay attention?
Yeah, I personally very much believe in market-driven solutions there. Compete, right? Create a better product that performs better than the ones that they're able to do and these features that they've completely neglected, and make them pay attention. I think for folks operating outside of the Femtech space, the Teslas, for example, just being vocal that this matters to consumers. And I think there is so much evidence that Gen Z and millennial buyers really care about how companies are value aligned with their own principles. And so continuing to be vocal around that. And of course, just like participating in political conversations, writing to your senators, doing all the things you always hear about to make sure that the infrastructure is in place for these innovations to occur.
Yeah. I would say data. People just know data. That's the world we are living in. Show them the money. Show them where it's at. You just gave a really good data. You're going to do something like this. You're going to lose $14 billion. That is expensive. That somebody should care about that. So if we are, bringing data in front of the decision makers, the likelihood that we can get changes done are going to be more likely with good data. By the way, reliable data that is interfaces in respect of not just financial costs of the problem, but also what does it cost to lose a mom? One of the things that I tell employers all the time, when you lose one mom because she went out on a pregnancy leave, but does not feel that she wants to come back because she's not supported in your place, she's going to go on a long-term leave that you're going to be paying for a very long time, and you cannot replace her. That it can be in a lifetime of an employer up to $100,000 a year of loss. So does it worth spending $60, $80 a month on this mama? So to avoid that 100 grand at the end of the day, that is a decision that people have to make. These are their ROIs and data that people have to see. And as we develop in more and more femtech technologies, the big guys will come in. They will have to decide, okay, if I want to partake, I have to look at that.
Yeah, absolutely. We have another question that came in about pelvic floor physical therapy. So Siggy, I don't know if you know the history of postpartum care and why to date we still only have women that had a vaginal birth only see the doctor one time after 6 weeks. She has stitches in her vagina. I'm not afraid to say the V word, y'all. Okay, that's what it's called. And she gets one appointment 6 weeks after. So pelvic floor physical therapy, there's a lot of muscles down there. They get stretched, they get torn, all of this stuff. Why is that not a part of the standard postpartum care? And is there a future that is going to be part of it?
Well, we're definitely pushing on that and bringing in, different experts for this, teaching moms pretermly to before she has her baby, what is she going to be doing after? So a lot of this conversation has to happen while you are pregnant. You should be already, putting in some, stretching mechanism in place, right? Using the oils, using the exercises, doing some work to prevent that from happening later. So if we get to educate mom and empower them in their pregnancy to know what to do postpartumly, that 6-week visit is less of an issue and more of, I can care for myself. I know what to do. Unfortunately, by the way, as you've seen, saying 6 weeks and a quick meeting, in the United States, the current data is showing that a mom, listen to this, from pregnancy, getting pregnant, all the way till 18 months of age, a mom will be in front of a medical provider, her and her baby, for an average of 15 hours. That's it. That's in 28 months, 24 months. So that is, that's all we get. So we have to do a lot for ourselves, and a lot of it have to do with education and empowerment. So we talk to moms about it all the time. You are pregnant now. Do things now that later on, once you have push this baby out of your vagina, it's not going to be all torn and distorted, and we can rebuild those muscles. And we do that right in pregnancy already.
We obviously have a healthcare issue because when you said 15 hours, I was like, that's amazing. But it's because I'm a millennial woman who's grown up on like 10-minute consultations, if that. So you're right. They deserve so much more than that. I want to talk about fundraising. So we have a lot of founders in the audience, a lot of investors, accelerator, directors here. Kiki, how are you able to fundraise on this? This may even go into the vice clause potentially, right? So how is fundraising going for you?
Fundraising has been an interesting journey. I would say that overall, even in the short time since we've started Hey Jane, there has been a lot more interest and attention given to femtech. I think a lot of these rallying calls are finally being heard, which is wonderful. That said, I think, a lot of these really common issues are still considered controversial. So 1 in 4 women will get an abortion in their lives. Doesn't really get much more common than that. And yet it is considered extreme. It does trigger certain vice clauses among a lot of institutional investors. And so it has not been easy from that front. That said, I have been very struck by the level of interest, by the level of empathy and understanding of the issue from investors that may not directly relate to it. And so hopefully there's a path forward. Not so long ago, investing in birth control was considered controversial, and now that's become very mainstream, and we're just on a slow path forward there.
Well, I so appreciate you leading the charge there and paving the path for future innovation. We did the Femtech landscape at Femtech Focus. I hope that's been dropped in the chat for y'all. It's a PDF document showing what are people working on in Femtech. And I think we only have 5 companies that we know of worldwide innovating in the abortion space, yet 1 in 4 women in the world will have an abortion in their life. So it's just a real juxtaposition there.
And more than once, right?
And more than once.
More than once, probably, too.
Yep.
So that's not just 1 in 4. I want to talk a little bit about fundraising and female tech in general. We are an older company in the way that we started off as a pilot in 2014. And we started raising in 2019 and actually decided that wasn't the wrong time to actually fundraise. Nobody wanted to talk about Femtech then, early 2019. So we just decided, okay, we're just going to go a different way. We're going to go through grants and pilots and other ways and stopped raising altogether. Started raising again in just now in April of 2021, just because we are in massive demand and really needed the money. Had an immediate, like a very different reaction. It was almost like 2 years have passed by, but the reaction was just completely different. So I do want to say that this has definitely changed. We got a lead investors within 2 months, and we are really halfway through our seed run. By the way, we are raising. We're trying to close the seed. If you guys are interested, please let us know. But we definitely are closer to closing the seed run in a very different way than we were in 2019. So sometimes I think it's just a matter of timing.
Yeah.
And I agree, Kiki, there is much more interest now than there was 2 years ago. And I believe that next year is going to be even more likely.
Oh, yeah.
We will going to see that explosion into that space and into the funding.
That's right. And look at Capital Factory being so on top of it, having Femtech panels before the big boom happens. Go Capital Factory. Kiki, there's been a question for you about your plans to expand into other states and what has been your biggest challenges so far to do that.
Yeah. So on the challenges side, telemedicine law is varied on a state-by-state level. And so for any, the simplest telemedicine model, it can be slow because of the state-by-state variation. Layer abortion regulations on top of that, and you can imagine that there's quite a bit of complexity. That said, we are now geared up to expand quite quickly into additional states. We have reprioritized some of the Texas border states towards the top of the list to really push forward there, given the sensitivity, the Colorados and New Mexicos of the world, and looking at other large states so that we can reach the most patients as possible with every launch that we do push out.
Amazing. We have one last question here I'd like to pose to you two, and then I'd like to end with an ask, because female founders don't ask enough, and I believe in asking. So get ready for your ask. But before we do that, there is a difference between gender and sex. And, I cannot tell you, I actually want to start like an Instagram that's just screenshots of how often I'm asked what's my gender, and then it says male and female, or what's my sex, and then it says man or woman. And I'm like, that's not what the words mean. Like we've been talking about this, and these are major companies like airlines and, major companies asking me the wrong definition. So we did have a question from the audience, which I totally appreciate, which is, what do you think about the evolution away from the word woman to terms like people with vaginas or menstruators or chest feeders and things like that for trans inclusivity?
Well, we're talking about birthing people. We don't anymore saying that's our term. It's birthing people. And we have 3 men in our group right now who are pregnant. Yes, they have a beard and they look like a man, but they do have a bellies. So we are very open to that change in the word. But birthing people is a better terminology these days to, at least on the birthing community. And then let Kiki answer the rest.
Sure. Yeah, we have made efforts across our site and all of our communications to convey that we do believe, abortion is a right for all people with uteruses, regardless of gender identity. We stray away from using the term women wherever possible. That said, I will say, I do hope that there's an evolution in language, and so that we get slightly cleaner and less reductive terms for some of these things. I don't like referring to our patients as people with uteruses. I think we are much more than that. And so we want to, I think there's a shortage of language right now that I hope is addressed soon.
I could not agree more. I get some heat sometimes for the word Femtech, and I'm like, listen, y'all, this is just a white label term for us to get some funding from Silicon Valley, okay? What it should be is just health tech, but yet health tech left out women for so long that we needed to come up with a word. And I am so excited for Femtech to even maybe phase out and it just be medicine. Just be medicine.
Exactly.
Right? Well, in our last 2 minutes here, I would love for y'all to give your ask to the audience. You never know who's listening. You never know who's going to watch this. So, Siggy, what's your ask?
We are closing our first seed round equity. So we are halfway there. If you want to invest in something that is good and meaningful and has massive amount of data behind it, let me know. We also looking for partners, hospitals, healthcare providers, FQHCs, and other who need our support. We are here to support you. Please reach out. Siggy@babyloveadvice.com. I would love to take this conversation. Thank you so much.
Amazing. Kiki.
Yes. So we just closed our seed. We now have some funding to really fuel growth of the team. We are hiring for product, ops, marketing, lots of things. So please check us out. And if you think it might be a good fit, drop us a line. I think they'll post our job board in the chat.
Are they allowed to be remote?
We are fully remote team, so anywhere in the U.S. is perfect.
Excellent, excellent. Thank you so much for being rockstar panelists. I was so excited for this topic, but you know what? I just love to talk about Femtech all day. It's really not a surprise. So thank you so much for your thought leadership and all your contributions to advancing women, female, and girls' health and wellness.
Thank you.
Okay, Brittany. I have been taking copious notes in the background, nodding my head wildly, wanting to throw in a bunch of comments. First of all, thank you. What a brilliant way to conduct that conversation, to bring so much pieces of data and really good questions to it. And I don't know about you, but again, I am blown away by the talent, the insight, the commitment of our female founders, and very focused and know this space and this topic and this set of healthcare needs. It's hard to find people that are really this on top of it. I mean, your impressions.
The femtech industry is filled with amazing men as well. And what I find is that I've worked in several industries. I've been in the dating industry, oil and gas, and all these different. The femtech industry is the most collaborative I have ever found. Our Northern Star is women are dying because we have not updated the speculum since the 1800s. Women are dying because nobody made a diagnostic, because there's no endometriosis is still a billing code called hysteria. Like there are just these things that we're outraged about, and we're coming together, innovators, founders, investors, mentors, doctors, government, policymakers coming together and saying, hey, this is unacceptable. And I have never seen so many partnerships and collaborations ever in any other industry. And it just makes me feel so good.
Yeah. And what I was taking away in listening to each one of them is, when we don't have women in rooms of decision-making and at policy-making, if there were more people who had periods, menstruate, pregnant, uteruses, all of those, we would not have nearly these number of issues. So you spend way more time on this than I do. Confirm that. So anybody who's thinking about moving into any type of a policy role, leadership, and you have that lived experience, we need you there.
Yeah. And it's a matter of, you don't know what you don't know, because society says that women's bodies are taboo. And so women aren't even allowed to talk about their postpartum issues, or their mental health issues, or their menopause symptoms, or whatever. And so it's not even the men's fault that they don't know what's happening, because society doesn't even talk about it. So that's why we should be included in the room.
And I wanted to pick up on a couple of things that I heard that I just wanted to reinforce again, which was, number one, men have postpartum depression. I think, it's like, okay, reminder, of course, that makes perfect sense. We need to be paying attention to that. Secondly, how maternity care deserts, how many obstetric care providers we're losing, why we're losing them. And I did want to raise the topic because I didn't hear it come up. And for those folks who are listening, we're not using nurse midwives in this country. We're the only country who doesn't have that as your first go-to line of care for healthy pregnancies. And so when you were talking about, the model that why is it one visit postpartum, that is the medical model. That's not the midwifery model. So I think that that's something that we need to think about, not only the technology, but different models of care, the different teams that we work with, the different providers. And to your point, there is another, when you were talking about this particular problem, I wanted to have a huge shout out to a midwife innovator. Her name is Jenny Krueger, and she has been focused on pelvic floor health, doing it at a global level, because many women, when they have poor global health, they endure stigmatization. They are shunned in their communities. Yeah. So you raise a really important topic that we didn't spend any time on, but I didn't feel like we could not have this conversation without including it. So
if you don't know what a doula is or a midwife,
absolutely,
check out the Femtech Focus podcast. We have plenty of episodes that kind of define it and talk about it. I didn't know what it was either until I got into Femtech. So there is no shame. I openly learn on the podcast while interviewing people. And, I think sometimes, to just wrap it up, like sometimes to innovate for the future, we have to look to the past, and women never birthed and grew children by themselves. And today we're living in a world where women are taking on that full burden, full time, by themselves. We're spread out. We're not living next door to our families anymore. Partners are leaving. We're very different society, and the pressure is on the women to hold all the plates up in the air. And so if we look back at this neighborhood approach, this community approach of supporting women, I think that's actually where innovation is headed.
And I do want to have one other question for you, because I want you to call this out. Venture capital. We need to be in. You make the case. I want you to make the case. Why is it a good business decision to get involved in the space of making sure that women have better health care than they're getting? Just make me the case, because I want every one of those venture guys to hear it. Venture gals and guys. I mean,
so the top 4 reasons to invest in Femtech. Number 1 is it's a $1.1 trillion market that is wildly underserved and untapped. So if you want a big market size with big returns, it's Femtech. Number 2, it's prime for disruption. Women are tired of being second class in the medical system, and we're willing to start using new types of products and innovations. So it's prime for disruption. 80% of our founders are female, and the statistics show that female founders rock. And last but not least, our average exit value is $301 million, whereas the average tech exit is $240 million. So again, if your heart wasn't moved by this discussion, but your wallet moves, the numbers are here.
All right. Well, you made the case well. And I'm hoping that everybody who's listening that has dollars to invest and gains to be made, not only in your wallet, but also in the health of our population. And when we get women healthier, everybody gets healthier.
That's right.
So anyway.
And you don't have to be an accredited investor to put your money towards it. Femtech Focus is a 501c3 nonprofit. We have a donation page on our website. So even $5 a month helps us do what we do.
Oh, you are so awesome. All right. With that, thank you so much. We're going to have everybody head over to our networking session. And in this networking session, the questions that I want you to ask each other are, how can you be an ally? How can health technology improve the health of women? We're headed into our final session. And as we were thinking about this health track for Austin Startup Week, we mentioned that healthcare is at a really critical moment. And there is not a single person across the globe who hasn't been dealing with mental health challenges. And I say this being very mindful that in this country, we've lost over 700,000 souls. And with that, it's all age ranges. But when we think about the toll of mental health and loss, I think we can all agree that the hardest group that's been hit with mental health issues has been our youngest citizens. It's hit everybody hard, but particularly with the number of children who have had their schedules disrupted, who aren't seeing their friends, who don't necessarily understand what's happening. I forget the exact number, but it's in the hundreds of thousands of children who have lost a parent, who have become orphaned, who have lost somebody really close in their family, who have had all sorts of disruption in their homes. And we're seeing that show up in our emergency departments. In the last year, the CDC has reported that there's been a 44% increase in mental health emergency department visits, not just mental health challenges, but kids showing up in a situation of crisis. And the toll of the COVID-19 on the mental health of children, it's a result of the disruption in the routines and the way we would normally pick up on these patterns and the way we would intervene with kids being in school and having their teachers and school officials and coaches being mindful and being able to see when something isn't going well. And we've had a disruption of going to pediatric care visits, going in and having those regular checkups because we stopped so much of what we thought of as non-essential care. And all of these factors has really contributed to this astronomical rise of crisis level visits. So as we consider this huge need and the range of solutions that are going to be needed, we're going to need to rely on technology because there's just such a great demand and our system has already been stretched to the limits to be able to provide it. So in this next segment, we're going to, if we can invite Karen Price, Dr. Karen Price up, and all of the rest of the panels. We've got a tremendous group of experts who can speak to us from a range of contexts and settings: schools, school nurses, school psychologists, physicians, those who are in the payer space, to really help us understand what it is that we're seeing, but more importantly, how it is that we are intervening with our solutions and our community and our professionals. So Karen, I'm going to turn it over to you. Take it away. I'm really looking forward to this conversation. Hey, Karen, I'm just wondering, are you able to hear? It looks like you might be on mute, just checking in.
Hi, good afternoon, everyone, and welcome to our panel on pediatric mental health and community interventions. My name is Dr. Karen Price, and I am the Chief of Psychology here at Texas Children's Hospital in Houston, and really excited to be able to talk with our panel today about different innovations and technology that we are using to address pediatric mental health concerns throughout the COVID-19 pandemic. I know my panelists will have a lot of really wonderful information to share with us all. I will start just with a quick question. So really thinking about the pandemic and how children's mental health was prior to the pandemic versus how it is now, I'm wondering if one of our panelists would kick us off by talking about what you have seen over the course of the past 19 months when it comes to children's mental health.
Sure, oh, go ahead. Who is?
No, please, Joanne, proceed.
Hi, I'll start with the introduction, maybe really quick. I'm Dr. Joanne Welch. I'm a general pediatrician. I practice emergency medicine and urgent care for about 17 years before I transitioned to Blue Cross Blue Shield, where I work right now. In my role in the ER, I encountered children and adolescents who were in crisis. So, hearing that there's such a significant increase in that situation, is very impactful. Once I transitioned to Blue Cross Blue Shield, I joined the team at C1 Innovation Lab as Executive Director of Operational Performance. And there, we really work with our employer clients to identify innovative healthcare solutions that impact our members. We really want to focus on that member experience, patient experience, and healthcare affordability. So going back to your question, can you ask your question one more time and I can make sure I get it right?
My apologies for not suggesting the introduction first. Just excited to jump to our content. So really was about what are we seeing in terms of children's mental health from prior to the pandemic and really evolving over the past 18 months or so.
Yeah, I think my comment would be, there was a resource issue with pediatric mental health and behavioral health resources prior to the pandemic. So that was a situation prior, and now the pandemic has just made it so much worse. And specifically for children who are at risk, what depending on the community resources, depending on social determinants of health, those factors are really just, having even a more impact on them, especially the disconnection with school. Unfortunately, many of our kids are back in school, but when they weren't in school, they were separated for a lot of that support that schools provided, and the learning, that support was significantly disrupted, and they had just a lot more stress. We're seeing ADHD, anxiety, depression, social isolation. A lot of these things are just, more impacted, more incidents. And it's not just the children, it's their family, it's their environment. And the parents are having to cope with this too, along with trying to homeschool their kids at the same time and work. So it's just really, cause a lot of stress, and dealing with that stress has been very difficult for a lot of children.
Thank you so much. I think that's a perfect segue perhaps into one of our professionals that are working with schools and in schools to go next.
Well, hi, I'm Lori Combe, and I have 25 years as a school nurse in a Houston area school district. I'm consulting now and helping school districts and education agencies to sort through student health and school nursing issues. Prior to my entry into school nursing, I worked inpatient adolescent psychiatry, and that really prepared me for this role in school nursing. I do want to provide some context because the public isn't always aware. Texas does not have a mandate for a school nurse. 35% of schools have a full-time school nurse. 25% have no school nurse. And those are nationwide statistics. And for the remaining 35%, they might have a part-time nurse caring for multiple schools over vast geographic distances. And that's very true in this large state with lots of rural areas. What we do know, and maybe Lori Klaus will confirm this, but of the 22% of adolescents who have a severe mental health diagnosis, 70% of them are receiving that care at school. So school really is a safety net. If you think it's just about education, it's not. We are providing health care in schools. And I think what's particularly concerning, and I'm fearful is exacerbated by the pandemic, is that suicide is the number 2 killer of children. The second cause of death in children ages 10 through 24. And while females may contemplate suicide, males are 3.6 times as likely to complete a suicide. So I have some real concerns for our students for many of the reasons that Joanne just discussed.
You're absolutely right, other Laurie. I am Laurie Close. It's very rare to have two LAURIEs on the same panel. I'm currently the president of the National Association of School Psychologists. Before stepping into that role, I have more than 25 years of experience working in schools and universities in the field of school psychology. And what we just very timely for this discussion, we just received some information back from our membership about what they're seeing as we try to go back to in-person learning. And the number one thing that our members report is that the incidence of referrals, if you will, for dysregulated behavior has skyrocketed. It's usually fairly predictable. You usually kind of know and can plan, but essentially it has skyrocketed. And that behavior can look anything like self-injury, aggressive behavior, withdrawn behavior, but all of that, really their emotions are flooding them, and their ability to manage those emotions is significantly impaired. And a lot of that is because what we know is that we're trying to do crisis response at a sort of a universal level, but we're still in the middle of the crisis. I mean, the first step in crisis response is return to physical and psychological safety. And we can't do that yet. We are not there yet to even begin to address some of these other responses. And so it's critically important that schools who are the first line, they're where the kids are most of the time, and they have professionals with expertise to look for those red flags, work hand in hand with community agencies. It's always been extremely important, and now literally lives are depending on it. And so I hope that we can have some interesting ideas about how technology can increase and facilitate and streamline some of those connections and interactions. Another thing we hear from school psychologists is the needs of the adults in the building are huge. So many of them have experienced loss, they're grieving, or they have increased anxiety around their own crisis response. And so, not only are school psychologists being asked to address the needs of more children, they're being sought out to address the needs of some of the adults, which is, that's a whole nother thing. I mean, there aren't really people in the schools to address adult needs. That's all referred out. And so that's a big stressor. And, unfortunately, what we're seeing is lots of school staff are leaving. They are simply walking away. Teachers are walking away. Instructional assistants are walking away. Psychologists are walking away. School nurses, because it is completely untenable for them to maintain their own sense of not even well-being, but just sense of sort of like almost well-being to stay in some of these situations. So, all we can do is support each other and try to come up with creative ways to continue to do that. And we will, because that's what we do. We figure it out. We are definitely building this plane while we're flying it. So we will continue to do that. And I look forward to this discussion about maybe some interesting ways to go forward.
Yeah.
Oh, go ahead, Ben.
Okay. Yeah. No, thanks, guys. Ben Kurian. I am a psychiatrist and executive medical director at Blue Cross Blue Shield for our risk identification and outreach program, which is kind of a multidisciplinary collaboration between behavioral health, medical, pharmacy, and data technology groups, where we kind of focus on trying to find at-risk member populations and implementing solutions for them at both a member and provider level. But kind of just to follow up on what all of you guys have said, the impact on schools, no doubt. And I think one of the points that Joanne alluded to earlier, if we take even a deeper dive and look amongst the different school districts, there's some data to say that there's a disproportionate impact on communities of color. So Black and Hispanic students especially seem to be mostly impacted, even more so with access, not only from an access to online learning perspective, but also from a negative impact with social and mental health perspective and access to care. So I think as we think through this solutions for this pandemic and the impact it's had on pediatric populations, we should place a specific emphasis on those populations.
I think that's a great point, Ben. And when we've looked at the inequities that the pandemic has sort of refocused us on and thinking about technology as one of those areas, I'm wondering if our panelists can comment on that. So we know that children are getting a lot of their mental health care in their schools. And at a very minimum, that's the place where grownups are laying eyes on them and watching them and seeing them. When schools are closed, when students aren't able to attend, or like you pointed out, Laurie, when there aren't enough grownups in the school, how do we stay connected to our students, to our children, to our adolescents in the community?
Yeah, I could take. Oh, go ahead. Oh, I was going to say, just kind of taking a step backwards and kind of looking at the pandemic factors that have kind of led to this, that have impacted the children and adolescents' emotional and behavioral responses, to kind of set the stage as to why this is such a complex and difficult situation. I mean, I think the number one thing is that how long this is the crisis has been here. And I think someone else alluded to this, that we thought it would probably be over by now. And we all kind of thought about, what does that post-pandemic life look like? And now we're trying to deal with, well, maybe there isn't a post-pandemic life. Maybe this is it, and it's a coping. And then the rapidly changing and conflicting messages that the older children and adolescents, they hear, and it's confusing because the information is constantly changing, the quarantine and the physical isolation. The other factors of the pandemic that affect children include the uncertainty about the future. There's huge uncertainty. We don't know what's going to happen in 3 months and 6 months. And separation from supportive people in their lives, like their grandparents, or if they have, like was mentioned before, the loss of a parent. All of that in the school setting is impacting these children and families. And also on top of that, adolescents are in a developmental stage of growth. They're defining and discovering their role among their peers and their community. They're forming their values. And this social isolation that they've gone through has completely disrupted that. So I think, to the question of why, what kind of innovations and how we can impact these the children's this disruption in their normal lives is huge. And I think definitely technology can help with that. And I don't know. I mean, I think e-health has been a great way to try to bridge that gap. It's not perfect, and it's definitely one of the many factors of the solution.
And I would say that there certainly are disparities in access that students have to care, particularly mental health care. And IT or mental health can solve that as long as the proper reimbursement structures are in place. And the other thing we have to remember is that the health services provided in schools are in large part funded through education dollars. And so that in part speaks to the disparity in access to health services within school systems. I think, as a school nurse and as the past president of the National Association of School Nurses, and hearing our members talk about the barriers they reach, I remember having students in crisis, and we couldn't access a provider for them. An appointment was weeks or months away. There were no beds to house that child. If we could find a bed, it was a very short-term emergency care, and then they were released back to school. Many times without adequate care coordination to understand how we best transition that child back to the classroom. And I think that telehealth can help to bridge that gap. And I'll point to the Texas Tech Medical Center, and they're serving a multitude of school districts in their catchment area in rural Texas, trying to meet that need, the Rural Mental Health Initiative.
Yeah, I think that's, that is all very much on point. And it's sort of like any inequities or disparities or disproportionality that we observed before have only been increased and magnified by what we've been going through. And I think, there, to me, kind of what's bubbling up is there are sort of three kinds of students who need services that we're seeing. One is the student who needs a service and has embraced the teleservice. And some even like it better, whether it's instructional or mental health services, because it's more individualized. There's more privacy in some ways, because they're not having to leave a classroom and go somewhere that everybody else isn't going. So there are some students who've really embraced it, and they have adequate resources to do so. There are others for whom it's not a good match because attentional issues or anxiety issues or resource management issues. Although there have been, some school districts have really done extraordinary things in trying to create access points for their kiddos. But then the third group that I am just terrified for as we move forward are the ones that are missing. And when I say missing is they didn't attend virtual school, they haven't come back to in-person school, and literally no one knows where they are. And that to me says those kids are extremely at risk and they're out there. And so we're going to have to figure out ways to find them. And they all have phones. So there should be ways that we can use technology to get those kids back who have left schooling, if you will, during this time. So I think, the sky's the limit, and people are so creative at how they can figure out to use technology. That program at the Texas Tech Med Center is really being shown throughout the U.S. as a model program of how to work with school systems to make sure you're getting to the most kids you possibly can, especially in underserved areas. But, it's one more thing. We can't, just because it's hard, we can't let that equity lens be clouded. We have to always have that lens when we're talking about increasing service delivery modalities.
Yeah, Lori, I wonder if that service you're talking about through Texas Tech is affiliated. I know the Texas legislature during the pandemic passed Texas Child Health Access through Telemedicine Act, which was designed to deliver telemedicine services to public school students that were experiencing more of an acute mental health crisis to kind of just stabilize the crisis. But I wonder if that's affiliated. Just to add on to some of the things that you guys are saying, from a payer perspective, we saw a dramatic, well, we've always supported telehealth solutions at Blue Cross Blue Shield, a dramatic increase at the beginning of the pandemic that continued for the majority of 2020, where we almost went from, low percentage, less than 10% of visits for pediatric behavioral health visits were done virtually. And then in the midst of the pandemic, over 50% of those were done virtually. While that trend is start to stabilize again, I think the genie's out of the bottle and telehealth solutions are here to stay. And definitely it provides solutions, especially for those communities that may be in rural areas where there are no behavioral health providers, so to speak, or where there's an access need and there's a shortage, we know, of pediatric behavioral health providers in general. So this is one solution to try to kind of meet the demand that's already exists.
Absolutely.
I'm thinking a lot about those kids that you mentioned, Lori, the ones that we just don't know where they are. And I start thinking about some of the solutions that they've used in medicine and in surgery with sort of shared electronic health records, so that if a patient at Texas Children's is seen down the road at Memorial Children's, we still can see that. I'm wondering if there are any thoughts or ideas about innovations, technology that we can use to broaden that safety net, or at least link the different safety nets. We've got the safety net at school, and we've got the safety net at the pediatrician's office, and hopefully safety nets throughout the community with different organizations or religious institutions and those sorts of things. Any ideas from the panelists about how we could join our different safety nets to capture more of the children?
Yeah, I think you said it. It's a lot of it is, connecting the information. So if you do have that child that is lost, to the school system, if they show up in the ER, somehow that's flagged as, somehow there's a connection. And I think that's, just in healthcare in general, that, being disconnected, whether it's with the payer, the provider, the patient families, the community resources, there's just so many silos that prevent us to, make the child's physical and mental health, reach its potential. So I think it's really a lot of the innovation has to deal with making sure that the resources are connected.
Absolutely. Yeah. And I think when you said some sort of flag, if a student shows up, or a former student shows up in the ER, I also think about some way to involve the juvenile justice system in terms of when they receive students who have what most would consider fairly clear mental health issues. If there was a way that they can then, instead of going incarceration, to go more therapeutic, that sort of thing, that would be a really important information sharing system.
Certainly there's some legal hurdles to manage there.
Well, yeah.
Right. We should just always remember that. So, but I think for my part and for my colleagues' part, care coordination is a critical role that we engage in making sure that healthcare is translated from provider into classrooms. Sometimes parents, for many different reasons, are very hesitant to allow conversation between schools and healthcare providers. And it really is a detriment to the care of the student. And so we try to work through those processes and understanding what parents' hesitation is centered about, to educate them about the value in care coordination. So it would have to be great partnerships between providers and schools and payers, et cetera.
Yeah, I'll just be brief and echo some of the sentiments that you guys just shared. It is going to take a collaborative effort between treatment providers, school districts, the legal system, and payers as well. I'll highlight a couple of examples, though, that are already underway that are kind of doing that. So one, if you look at the UT Southwestern Center of Depression and Research in Clinical Care, they partnered with various school districts here in North Texas, where they're actually going into schools and doing depression screening and education, as well as suicide education. And it's part of both an opportunity to increase education and awareness in the schools, but then also to have a better understanding of studying the course of illness amongst some of our youth. So that's one that I'll highlight. The other one is the Meadows Mental Health Policy Institute, who do a fantastic job of many of the things that you guys have just highlighted in pediatric populations, geared towards increasing access to care for various at-risk pediatric populations, including the juvenile justice system.
Yeah, and I think another thing that would help is just the universal screening. I think it's, pediatricians, I think in general, we need to do a better job of just implementing and putting into practice routinely at every visit, screening, depression screening for, any risks the child may have, connecting with that family, seeing what kind of situation the child is at home, and then identifying the children at risk early, and implementing, whether it's support or resources early, and then getting them referred for those children who need referral. But it's really, trying to diagnose them. So, when we see it, 1 out of every 4 children has a emotional and mental health condition, we really need to diagnose early and get them the treatment as soon as they need.
So we encounter in our offices those children who present with somatic complaints that after referral can't be substantiated, right? And we recognize that those children either don't have the language for emotion, or they associate stigma with the expression of emotion. And so we're in a position to help them articulate, to educate them about the physiology of emotion and how it presents in their bodies, help them to articulate, to help them access services, whether it's within the school or to refer outside of the school. And so I think that early identification is so key in helping mitigate mental health concerns.
If we think about the parents, the family members who are in our audience today, and they're wondering, what should I be looking for? So now we've heard a little bit about what pediatricians are looking for, what our school nurses and our school psychologists and teachers are looking for. What should parents be looking for to know if their child is at risk and might need some help?
Yeah, I think it depends on the age of the child. I mean, the child's response to stress really depends on their developmental stage and the context that they're receiving or feeling the stress. For infants and toddlers, they may manifest distress through disruptions in their regular physiological functions, which means toilet training, feeding. They may have more separation anxiety. They may regress, from eating solids. They may not want to eat solids anymore. They may withdraw socially. I think if it's a preschool child, they may be more anxious. They may have more obsession or obsessive thoughts, compulsive practices. They may not want to leave the house. Older children and adolescents may have, more apt to internalize their symptoms. They may withdraw from, activities. They may be fearful, have anxiety. They may, have other behaviors like, defiance. They may be irritable, aggressive. So, and then some of the other children, like you said, older adolescents may, then recognize that there's a stigma associated with mental health and admitting that they're having a problem. They may feel fear or shame, and they also may not want to burden their family with admitting that they're having difficulty. So they may not say anything. They may internalize it. So, as far as what a parent, if it's differences in their daily routine, if they seem withdrawn, if they're regressing in their behavior, if there's things going on at home, like the pandemic, or a loss of a job, or a loss of the loved one, or they're getting evicted, or the parent is trying to work from home and school their child at the same time. All of these things may cause these symptoms that the parents will need to look for. And it's hard because, again, the parents are experiencing these things as well. And the parents may not be emotionally available or as supportive as they can be because of what they're going through.
Absolutely. And I think, the developmental differences are confusing and astronomical to those of us outside of this world, but the thing that I think is consistent across ages is looking for dramatic change. The child was one way and all of a sudden they're another way. So maybe they were gregarious, outgoing, and suddenly they're fully introverted. And so it doesn't, it's a flag. And sometimes the flag plays out to be something and sometimes it doesn't. But when you have a dramatic change in your child, whether it's a developmental task, a personality trait, their relationship with you or other people as a parent, then that's when I think that's a flag and you start to investigate more.
Yeah, I'll just follow up real quick and agree with both of you guys. A couple of websites that we may be able to highlight. NAMI, the National Alliance of Mental Illness, has a good website that talks about warning signs and symptoms for parents. And the National Institute of Mental Health similarly does the same. But just to kind of piggyback on what you were talking about, Lori, those sudden changes, especially when they occur in a couple of domains, right? So sudden changes or differences in things like school performance, changes in sleeping or eating habits, and then sudden changes in social life, right? So either avoiding friends or maybe a new friend group, things along those lines. Not to say that those are always going to be signs for mental illness or disorders, but something to look out for and to dig deeper.
And I think to help with that, if parents are seeing any of these signs, it doesn't mean that the child has a diagnosable mental health condition. It just may mean that they need support. And so there's a lot of innovative apps, mobile applications out there that the parents can tap into. There's a huge resource. I can't even begin to list all of them, but a lot of them have to do with whether it's mindfulness or guided meditation and breathing, dealing with stress, understanding emotions. So there are resources that don't necessarily mean a referral, to a mental health professional. It could be something that the parent can do with the child, but they need to be aware. And so families can, reach out to their pediatricians, reach out to their local mental health authorities, schools, school nurses, let the teachers know. A lot of times the teachers and school nurses know things that the other people aren't picking up on, to try to get and identify those resources.
Thank you all for those great tips, as well as the different technology pieces and how to reach out and get more information. Want to make sure that our audience members have some time in our last few minutes. If you have any questions, please feel free to put them in the chat and we can see if our panelists can answer them. We do have a question about a somewhat different kind of stress, and this audience member is asking about educating family law courts about the needs of children during divorce and custody battle. And I know that's not exactly our topic today, but when I think about parental stress and the impact on children, I can see a parallel there. I'm wondering if any of our panelists would address that question.
I don't know if this really addresses it, but what I will say is that I know that school psychologists and the National Association and certainly the state associations are constantly working with legal entities, whether they be legislative or judicial, to try to help educate people about child development, child mental health issues, and the impact of environmental stressors. So I would imagine that other, organizations are doing that as well. And, and sometimes that's really the most we can do is just continue to provide information and say, this is a reality of what's happening. This is what we know about the impact of stressful events on child development. That is a hard system to break into for sure.
Have another couple of questions from the audience that are related. And so the questions are, do schools and school districts know how to deal with these problems? And how can we better prepare teachers to help?
I would say that the school districts certainly have crisis response plans to manage mental health concerns, but proactively, many schools are taking a trauma-informed care approach. And so helping staff to understand trauma and adverse childhood experiences, also helping staff to come to terms with their own trauma before we can expect them to help students address the trauma in their lives. So, it takes education, and schools have a vested interest in making sure that staff are prepared to address these issues within classrooms.
Yeah, and I'll just echo that right now there is more attention focused on that than there ever has been in my professional career, in terms of awareness and a need and the role that all the adults in the building can play. It's no longer just, send them to the nurse, send them to the school psychologist, send them to the school counselor. It's a really an increasing understanding that all the adults in the building have a role to play when dealing with someone in crisis, when dealing with someone who's showing a red flag, or when just supporting the mental health overall of all kids.
Right. And one of the comments, it's hard to be a counselor and a teacher, and I would agree, specifically, or especially, I should say, when you think about class size and class loads and how to balance the attention that students need to support their learning and then deliver education to that whole classroom. We know what role does mentorship play. It takes one caring adult to make a difference in a child's life. So mentorship is huge. I know that my school district has still, even though I'm gone, but they have a mentoring program, and I think many school systems do, where they train adults to support individual students.
Any other thoughts or ideas from our panelists on how community members can support youth and adolescents who may be experiencing mental health concerns or really just stress related to the pandemic and all of the adjustments? So not necessarily as parents, not necessarily as teachers, and not necessarily as mental health professionals, just people who live in communities where children live and where we want to see them thrive.
Well, I'll harken back to mentorship programs. If your school district, your community offers that, or you have a boy and girls club, step into that role to support students.
And I would say the awareness and just being open to talk about it, knowing that, having a conversation, talking about if you observe anything in a child or have a concern, open that conversation and, connect with the parent or, community resources to help.
Yeah. Look toward, not away. When you see someone experiencing difficulty, look toward them, and just the simple words, "Can I help?" And a lot of times the answer is no, but it's a first step. It's a step as a community saying, "I'm not going to isolate you. I'm going to embrace you."
Yeah. I think programs like this, right? The more we can spread the word and awareness, increase awareness about mental health, mental illness, the more we can increase the community's awareness about that, the better job we'll do of recognizing it. One of the things we struggle with is depression and anxiety goes under-recognized, untreated. If we can do a better job of recognizing that and getting access to care, then I think that'll go a long way.
Well, I'm going to jump in.
I think one of the things you're all alluding to is stigma, and how do we break the stigma around mental health, around mental illness, especially as it pertains to our children. So any last comments on that piece?
Talk about it. Talk about it. Talk about it like you would talk about a cold or the chicken pox or whatever. Just talk about it.
Normalize it.
Yeah, I used to do research in depression and anxiety at UT Southwestern. That's what we would do. The same thing that you guys are talking about, right? If you go to see a primary care doctor, he's gonna check your blood pressure to make sure you don't have hypertension. The same thing should be the case for depression or anxiety or substance use, right? Asking questions about them. That's the only way we're gonna know if somebody's suffering from that illness.
So, Karen, I was going to jump in here. First of all, I want to thank you guys for caring about our kids. And it's, as somebody who has had 3 children now in their adult phases, I look back and I think how grateful I am for the teachers and the care providers along the way. Not only did they keep them safe, but they taught them a lot. Anytime many of us have been into a classroom, we see just how hard this is. And as much as I am a techno optimist and somebody who loves technology, I want to be an advocate for you guys because I think technology is great and it's going to be really helpful for our solutions. But Ben, Joanne, I want to target this at you. Technology is great, but I think in this instance, policy and resources, there's no amount of technology at this moment in time that is going to overcome the need for policies and resources that are going to help us address the future needs. And I want to ask you two specifically to address this. Every bit that we invest in our children in the earliest stages, tell me how much we're going to get back on that investment by investing early when the problems are at their earliest stages.
Yeah, that I think that's a wonderful question. I mean, it's just like with a physical condition, right? A child who has diabetes early or has a lot of urinary tract infections, they're going to have, renal issues, have to have a renal transplant later. You need to catch it early. The earlier you catch it, the better their outcome will be. And so when we talk to, the legislation, why do we only have so many nurses in schools, when we have this huge problem? I mean, that's a big issue. How can we connect our schools with our providers if we don't have the school resources? And we just have to we have to prioritize. It's like education in general. I mean, I think, I really appreciate the school, the input from the schools in here is that is a huge amount of time that children spend every day at school. We need to really, incorporate that into their, their healthcare, their holistic healthcare, mental and physical. But yeah, investing in the children early is essential because think about, as they go into adolescence, as they go into adulthood, we want them to reach their health potential, and their health potential is, being healthy physically and mentally.
Yeah. And so many of the school nurses, what they're there is developing the readiness to learn. So they have to have all of these health pieces. And where you guys sit in the healthcare space as a payer, you're seeing situations that come up with a diagnosis that's got a treatment and a pathway to it. And we want to be way, way, way early for that. And I'm curious, as we're sitting here talking, the thing that I'm noticing when we talked about lost children, and literally kids, we don't know where they are, across the country, school systems everywhere have reported thousands of children unaccounted for. We have no idea where they are. And when I think about those solutions and who are the innovators that can help us, shame on me, we didn't invite children to this table, because I think peer and some of the best solutions come from the beginning mindset and from our students, from our youngest innovators. So I'm making a note to myself and putting that out there to all of those who are listening, and to our school psychologists and school nurses. And we need to be tapping into our kids. They really have some great ideas, and they'll be able to help us move upstream. And the other piece that I wanted you guys to focus on, or just to comment on, when we think about these policy changes, and we're seeing legislation that looks at Medicaid expansion, making sure that moms have full coverage during their pregnancy, making sure that we have care that is in school, making sure that dentistry and all of our senses are covered in all of this. It seems to me like one of the greatest innovations that we can have is legislative innovation, and making sure that people are registered to vote and they develop a healthy habit of voting, and that they vote through a health lens. So I just put that out there to you from the standpoint of, I want to make sure that we raise that topic, because you as a professional, as a group of professionals taking care of kids, you need a lot of help from the community. And I'm curious if there are legislative innovations that you can think of that is an ask to the community that's listening. How can we as a community be better villages and stewards of our children and our future? Ben, I'm going to start with you.
Yeah.
You have that sigh, that heavy sigh.
Well, no, I think we talked a little, I think along the lines of what you're talking about. We talked a little bit about one earlier, right? So increasing telehealth access, especially for at-risk communities. So when we talked about lost kids, the predominantly where that's occurring are in minority communities. So where there's difficult access to online education, right? So when there was a dramatic switch during the pandemic to online education, if you don't have stable internet access, you're not going to be able to do any sort of learning. So that was predominantly occurring in socially economically disadvantaged communities. So if we look at it from a legislative standpoint, targeting and focusing access not only to internet, but also access to care in those communities. And the easiest way to get both of those things accomplished is through telehealth, right? That's how we can meet the demand with the supply. So I would say that and maybe the recent legislature during the pandemic, their approval of the Telehealth Act to increase access in schools, I think that's a first step to go a long way. And then supporting agencies like the Mental Health Policy Institute, who that's their sole, one of the things that they really hearken on is to try to improve access to care especially for pediatric populations.
Laurie Combe?
Well, I think we've talked about equity in access. And what we know is that when a healthcare provider looks like me, my outcomes are better. And so how do we legislate support to fund education for diverse communities to enter the healthcare field so that they can work in communities with people that they know and understand and have similar lived experiences, so that we can improve the health outcomes of all.
Yeah. Karen?
I would just echo what Laurie just said. So I think speaking to not only growing the pediatric mental health care workforce, but also diversifying the pediatric mental health care workforce. And certainly in terms of language and ethnicity and race, but also in terms of developing that connection to the community and supporting education programs that connect psychiatrists, psychologists, social workers to their communities so that they want to stay there and build and grow there instead of taking their great education elsewhere.
All right, Joanne.
Yeah, I would say the awareness is really important, and that every individual has a role to play in advocating for, what's right. And so I think instead of, waiting for somebody else to do something, we need to all take a look at what we're doing and see how we can contribute, because that's really what's going to get the momentum when it comes to the legislature. Also, sorting through, making sure that we are educated and that we have the information. So being able to sort through the misinformation that's out there was named, a public health threat to our population. So I think that's what we need to be look within ourselves and be activated.
Laurie Close, I'm going to give you the last word on this.
Woo.
And I want to end it on a happy note.
I'm going to.
I just want to say, from the standpoint of, tell us all, how do we put the happy back in a happy childhood? Because right now it hasn't felt all that happy.
Well, you know what? But you know what? The cool thing is that it is still happy. It's fully 80% of the kids are just moving right along, doing their thing. We tend to focus on the 20% who need us, who need the things that we're trained to do. But, we never see the 80% that are doing just fine in spite of everything, because kids are so resilient. That's why early intervention is critical, because, their little brains are still developing. They're still making those connections. They still have hope. That's why we can never give up.
That is so true. And I'll tell you, when people ask me what gives me hope, it's our youth. When I see how much they care about the environment, that they care about other people, refugees, they care about their teachers, they care about their pets, they care about their families. I feel like we're in good hands, and it's just up to the adults around them to be better, be the better humans that they need for us to be. So again, I want to thank you guys so much. I want to thank Texas Children's for helping us to support this track and really help us to focus on the well-being of children, which I think is the well-being of our future. So again, thank you to you all, and keep doing all these great things, because heaven knows our kids need you.
Thank you.
Thank you.
Thank you.
And with that, we come to the close of the health track for Austin Startup Week. And I'm hoping that I'm going to have my colleague, Haley Gurin, join me. Haley, are you coming up?
Hi, everyone.
There you are.
I don't have the cool background, but.
Oh, yeah. So I just want to get your take. First of all, we have a lot of people to thank. You're one of them. There are, the magic of technology has put us in front and connected us with people who have really great ideas. The audience who joins us, when people come to these things, they want to learn, but also they have ideas that they want to share. So I am so grateful for a very active audience who's been peppering us with really great comments and connections and suggestions. And I'm excited for all the connections that are happening offline. And then we've got all the magic magicians who are behind these scenes, like you, who are moving people around, putting signs up there, moving us in and out of green rooms, making all of us look like way smarter than we actually are. So I just want to say thank you to Haley. And I know Sam's back there and Michelle's back there. You don't see them, but oh man, thank you guys. This has been great. Haley,
yes,
thoughts about what you heard today?
Well, I have to say, many of my colleagues sitting in our command center here at Capital Factory in Voltron, controlling all of the green rooms and the live stages for Austin Startup Week, we really enjoyed the Femtech panel. We're really grateful that Dr. Barretto was able to join us. She used to be a Capital Factory employee, just like ourselves. So that was really fantastic. And, myself, I hope that she made a good point when she said that Femtech should be health tech. And I think that's a really important thing to take away from today, especially for all of our male allies watching. And I just hope that all the VCs watching, put those dollars in those companies and recognize that it's a huge market and we need the help and we need the allyship.
We do. We absolutely do. And particularly when there are policies and legislation that don't really line up with
Absolutely.
the realities and the needs. So, yeah, interesting. We are living in interesting times. And what I'm hoping is that as we bring to light the information, the data, and every data has a story behind it and somebody's life. And when we have a better understanding of that, when we lead with empathy, with kindness, with love, and we back it up with really good science and the remarkable technology that's available, and we use it to its best and highest purpose, we've got tons of capital that we can deploy that really has a financial impact. It makes our economies run better. It improves our lives. We just have a lot of resources that we can do good things with. I mean, money is a tool for doing more good things, right?
Yes, and we also need all of our, other folks that don't exactly work in tech to help us solve these problems, especially in healthcare. Not everyone's in tech, but so we need you and we need your input, and we need you here at Capital Factory. So
yeah, well, and I want to give a huge shout out to Capital Factory for hosting Startup Week. Again, we're missing all of the in-person energy. We've got, some hybrid things going on, but I have the distinct pleasure, it's a treasure actually, to be able to travel around the world and be involved with all sorts of innovation agendas and innovation economies. And every single time I get on a plane, I am always so glad I'm coming back to Austin. One of the things that I think that Austin does as far as a startup community is that we're here to listen. I refer to it as we're pathologically helpful. We want to see people succeed. And it doesn't matter how many times you're going to give your pitch. We want to listen. We want to see you progress. We want to connect you to that. And I think that Capital Factory has definitely been the center of gravity for that. They are the convening force. And every single time we have an Austin Startup Week, we bring together a group of people who have a bias towards action, who are doing hard work and solving hard problems for all of the right reasons. And I am so grateful to be a part of that. And I guess we need to close this up and say goodbye, right?
Yes. And
Okay.
also I'll go ahead and put the shout out that we're having a meet and greet / happy hour at Irene's following this event. It was sponsored by Sana Benefits, who Tony Tovar hosted the mental health and wellness track this morning. So everyone who's out there, we hope to see you at Irene's between 5 and 6:30. Irene's is located on 6th Street and West Avenue. Most Austinites know where it is, but we hope to see you there and to continue these discussions. And Shawna,
I was going to say one other final thank you that I need to make sure I get in. I really want to give a shout out. I mean, Capital Factory and putting this stuff together, we want to say thank you again to our sponsor, Texas Children's Hospital, for supporting this track, for Amazon Web Services for supporting Austin Startup Week, and again, to all of the team and everybody who has spent a lot of time thinking about who are those ideas. I mean, who's got those ideas? Who's leading the way? How do we connect with them? So putting this together, we're grateful for their unique perspective and insight, because they're so close to the problem. They've got a really good understanding of what the solution looks like. So I hope that you will say hi to me on Twitter. I'm at Shawna Butler RN. Please reach out to me on LinkedIn. There's some great stories on the See You Now podcast that, again, focus on how we're solving these really vexing problems, but really interesting stories about how people see the problem and they solve the problem. So Haley, I'll leave it to you to finish up the goodbyes in case I forgot anything.
Yes, everyone, listen to See You Now. It's one of my favorite podcasts now. Amazing stories, especially focused around health equity. And speaking of equity, if you'd like to reach out to me, I'm the Diversity, Equity, and Inclusion Coordinator here at Capital Factory within the programs team. So please contact me on LinkedIn or contact our @CF Diversity account. And we'd love to build more events and build more focus around these issues. We'll see you all at Irene's. Bye, everyone.
Bye-bye.